Welcome to the deep dive. Today, we're really getting into something important, how expert therapists work through the tricky parts of treating PTSD. Because, sometimes even with a great therapist-patient connection, the progress just stalls.
That's right. And it's often down to these common obstacles, things like avoidance, which can be really subtle sometimes.
Right.
Or patients not quite connecting emotionally when they revisit trauma memories, either too much or too little.
Okay.
And then there's difficulty tolerating distress or getting stuck on one specific feeling like anger or shame, blocking everything else out.
So that's our mission for this deep dive. Figuring out how skilled therapists adapt their approach
Right.
using emotional processing theory or EPT to tackle those specific roadblocks.
Exactly. And having a solid grasp of EPT is, well, fundamental. The main idea has two parts, really.
Yeah, what are they?
First, you need to access the fear structure.
Right.
Basically, you bring the person into contact carefully with the feared situation or memory, get those emotions activated. And second, you provide corrective information. This isn't just talking at them. It's about creating new experiences that actually, concretely, show them their negative expectations are wrong.
So it disconfirms the fear?
Precisely. Shows the feared outcome doesn't happen. And this isn't just for fear, it works for other difficult emotions too.
Okay, so let's make that practical. How does this work with real-life situations, what therapists call in vivo exposure?
Well, say an in vivo task is just too overwhelming, like a survivor who's deeply afraid of unfamiliar men. You don't just throw them in the deep end.
Right.
You break it down. Smaller steps, maybe start with situations that feel a bit easier. Sometimes even having like a friend or family member tag along at first helps manage that initial distress.
That makes sense. But you mentioned subtle avoidance earlier.
Yes. And this is key. Think about safety behaviors. Like maybe someone only shops when the store is practically empty.
Or insists on having a female cashier.
Exactly. Or we had a patient, let's call him Antonio. He had this whole ritual with his keys, getting them ready way before his door, then rushing inside.
Right.
These behaviors get in the way because the person thinks, phew, I was safe because I did X, Y, or Z. Not I was safe because the situation itself wasn't actually dangerous. It prevents learning.
It's like a false sense of control that actually blocks real progress.
Yeah.
It's fascinating how our brains do that, isn't it? Trying to protect us, but sometimes boxing us in.
Couldn't have said it better. We saw this really clearly with another patient, Jason. His PTSD symptoms were getting worse, even though he was doing his exposure homework.
Wow.
Turned out he was unconsciously avoiding everything trauma-related outside of those specific homework tasks. Tiny avoidances he wasn't even aware of. It completely stalled his recovery until we pinpointed it.
Wow. Okay, so what about the other side of exposure, revisiting the traumatic memories themselves? Imaginal exposure.
Yeah. Right. The main goal there is for the person to engage emotionally with the memory, but, and this is crucial, while feeling like they're in control, not completely overwhelmed.
So they learn the memory itself isn't harmful.
Exactly. And that the anxiety, while intense, is temporary. Now, one common hurdle is underengagement. The patient seems detached, maybe numb.
Or uses very formal, distant language.
Yes, like calling an attacker the assailant. Very stilted. So the therapist gently reinforces standard procedures, eyes closed, speaking in the present tense. They might probe for more vivid sensory details.
And explain why it's important to connect.
Absolutely. Explaining the rationale is key. Sometimes the therapist might even carefully model some emotional expression showing it's okay. It's about teaching the brain this feeling in this safe place isn't dangerous. It's part of healing.
Okay, that covers being too detached. But what if it's the opposite? The patient is so distressed, maybe sobbing uncontrollably, really feeling like they're back there.
Yeah, overengagement. If they're so distressed they can't actually process anything new, the therapist has to ask, is this actually helping them learn right now?
And if the answer is no?
Then you gently pull back, reverse the procedures, eyes open, switch to past tense. Maybe try talking about the memory more conversationally for a bit, or even writing it down instead.
Grounding techniques, too.
Definitely. Using things like a stress ball, focusing on the feeling of a towel, or even just slow-paced breathing can help anchor them in the present. The goal is always learning and feeling safe now.
Okay, this is where I think it gets really complex. What about those other big, powerful emotions, like intense anger or deep shame? They aren't exactly fear, but they can definitely stop progress cold.
You're absolutely right. Take anger. It's often a totally valid response to trauma. But when it just dominates everything, when it's the only emotion accessible.
It crowds out other feelings.
Exactly. It can block the processing of underlying fear or sadness, which also need attention. So the goal isn't to eliminate anger, but maybe to gently move it aside temporarily to allow other emotions to surface. Interestingly, PE studies show anger often reduces even when it's not the direct target.
And shame, that feels like a tough one.
It is. Shame often thrives in secrecy. So one of the most powerful things is simply sharing the traumatic memory, often for the first time, with a therapist who is compassionate and completely non-judgmental.
That provides the corrective information again, doesn't it?
Precisely. It directly counters the expectation of being judged or blamed. That experience itself starts to reduce the shame.
We've talked a lot about managing what's happening inside the therapy room, the emotional processing itself. But what happens if someone's going through a major life crisis during treatment? Does everything just stop?
That's a really common question. Crises do happen, often linked to co-occurring things like depression or substance use, which themselves are frequently tied to the PTSD.
So they're often connected.
Very often, directly or indirectly. So unless there's an immediate, serious risk to someone's safety that needs urgent intervention, the focus generally stays on the PTSD treatment.
Really? You keep going.
Yes, because often addressing the underlying PTSD, reducing those core symptoms, is actually the most effective way to help the person build resilience and manage or even prevent future crises in the long run. Weakening the PTSD strengthens their overall coping ability.
So wrapping this up, our deep dive today really highlights how crucial it is to tailor PTSD treatment. It's about spotting that subtle avoidance, understanding whether engagement is too high or too low, and knowing how to work with specific emotional blocks like anger or shame. It's definitely not one size fits all.
Absolutely. It's about precision. And maybe if we connect this to the bigger picture for everyone listening, think about how understanding these specific ways therapists help people navigate stuck points, the avoidance, the emotional overwhelm. How might that shed light on our own patterns? You know, those times we all get stuck facing challenges in our everyday lives, something to consider.